twin epidemic of weight or obesity, scale, and glucometer. That is the twin epidemic which we are facing. This is the obesity and type 2 diabetes. How these things have mixed up, and recent years or the past decade, how things have changed or evolved or revolved into a demon of diabetes, which we are all facing with lot many micro and macro cell complications. I will start with a blessing from Dr. V. Mohan. Lessons learned from epidemiology of diabetes, South Asian patients, and this is Kelly West Lecture 2024. Friends, just look at the lessons learned. Till around 2000, what we were having migrant South Asians. They were having much higher prevalence of type 2 diabetes than native South Asians. So those South Asians who have migrated to abroad, they were having higher chances of development of type 2 diabetes. So that was the story in 2000. What happened? From 1991, the Indian economy opened up. There was liberalization, globalization, and socio-economic status improved, and our wallets start swelling up, and economy grew rapidly. And then comes along with that, under the carpet, obesity, overweight, and then type 2 diabetes rates start soaring up. Lesson 2 is that in US and elsewhere, South Asians have higher prevalence of type 2 diabetes than other ethnicity, including other Asians. So that was a story. But what happened? This trial, that is Cars and Masala study, that showed that in 40 years, everything has changed. The clock has turned full circle. Diabetes rates in native urban South Asians are now much more higher than in the migrant urban South Asians. There can be so many issues which have propelled this increasing prevalence and occurrence or incidence of diabetes. Projections are very grim. More than 100 million people are having diabetes, more than 136 million people are having pre-diabetes, and numbers are growing every year. We have got hypertension in roughly around 315 million people, generalized obesity in more than 260 million people, abdominal obesity more than 350 million people, and dyslipidemia is more than 200 million people. So this is the burden of non-communicable disease which we are going to have. Just focus on this cartoon. The takeoff point at BMI in comparison to Western or Caucasian counterpart is much more earlier. Much more earlier. It is steep rise just at 22 kg per meter square. Even before that, you can find in women and also in men across South Asian countries, specifically in India and Pakistan. You can see how the takeoff point of increasing diabetes prevalence starts just after 21 to 22 kg per meter square BMI. We have got very different phenotype. All we are aware, it starts at lower age of onset, more 10 to 15 years earlier than the Caucasian counterparts. We are hyperinsulinemic. We are severely insulin resistant. We have also decreasing beta cell insulin production capacity also. There is rapid decline in beta cell function also. We develop diabetes much more at much more lower BMI. We have got low birth weight. We call ourselves as a thin fat Indian. We are sarcopenic. These are the things we are accepting, and these are all pathophysiological factors leading to increased propensity of development of diabetes related complications. Not only diabetes but complications also. Characteristic dyslipidemia, where HDL is low, triglyceride is high, and small dense LDL is high. Low level of adiponectin, high hsCRP, high markers of inflammation, high NFLD, roughly around 80 to 90% type 2 diabetic patient, low B12 level, low vitamin D, and altered gut dysbiosis. So that is typical South Asian phenotype. There can be various reasons. One reason, our meals are different. We consume lot of carbs, we are sedentary, and we have got genetic predisposition also. But the environment is the biggest culprit. If you look at the amount of insulin secretion, we are basically hyperinsulinemic, but also you can see here HOMA-IR. HOMA-IR is much more higher. That means insulin resistance is also much more higher in comparison to Western counterpart. But see the beta, HOMA-beta, the beta cell production capacity is much more severely lowered in comparison to Western Caucasian counterpart. So Asian Indians, they have got higher insulin resistance at early stages in the natural history of type 2 diabetes compared to white European. This is mainly driven by ectopic liver fat. But we have got much more important issue, that is severe insulin deficiency in comparison to insulin resistance. So that is much more predominantly there in Asian countries, Asian population in comparison to Western counterparts. We have got very different subtype. You can include two type of things like combined insulin resistance and deficient diabetes. This is different. This is unique from Western counterpart. Another lesson: we South Asian, we have got more IFG in comparison to IGT. So how this is related clinically? This indicates we have got insulin resistance at the level of hepatic tissue, at the level of liver. It is increasing more hepatic glucose output, leading to increased fasting plasma glucose. Then it is again giving us much more implication. The patients, the pre-diabetic patients who are predominantly having impaired fasting glucose, they are much more tougher to get to decrease conversion from pre-diabetes to diabetes. They are much more resistant, much more tough to get decrease conversion from pre-diabetes to diabetes in comparison to those patients who are having predominantly impaired glucose tolerance. So this is the lessons we learned from Kelly West lecture of our professor Dr. Vimon. Ultimately summarizing, phenotype is thin fat Indian. We are all aware. It continues throughout the childhood, even in the adolescent also. Stage 1 is hyperinsulinemia and insulin resistance, increasing abdominal fat, and that overflows to liver. We develop ectopic fat, that is stage 2. There is rapid transition to exhaustion of beta cell due to beta cell functionality goes down due to lipotoxicity, glucotoxicity, leading to severe insulin deficiency and South Asian type 2 diabetes phenotype. Causes can be many, but the solutions are very aptly there on your right hand side. The lowest block, you can just, the rectangle, you can just read: improving nutrition in the mother. Pre-pregnancy counseling important, nutrition counseling is important. Intrauterine value is extremely important. As Dr. Vitul was saying, this intrauterine environment gives a blueprint the child or the adolescent, the person is going to have. From childhood, modify the lifestyle, make them more exercising, make them less chubby. Carbs decrease, protein increase, fiber increase, more exercise, less sedentarism, and try to avoid pollutants. Avoid pollutants in all form. They are endocrine disruptors. This is another article which was recently published in Lancet that showed that that was 197 countries, and India was part of these. Nearly half of adult population is physically unfit. This is Indian population. Physically unfit are 22% in 2000, but in 2022, men are 50% physically inactive, and women, more specifically, are 57% physically inactive. By meaning physically inactive, 150 minutes of moderate intensity exercise per week or 75 minutes of vigorous intensity exercise per week are not done. So that's why they are not labeled as physically inactive. Among 195 countries, India has 12th highest prevalence of physically inactive person. And if it remains like that, 2030, just 5 years down the lane, 60% of our adults will be just unfit. And global estimates are enormous of healthcare costs when you are going to spend for this physically inactive people. So we have evolved. We all say we have evolved. We have got good, luxurious homes, and everything is there. And we have got everything in our hand, and everything is driven by remote. So Neanderthal man, Homo erectus man, Homo sapiens now become Homo obesticus. Obesity trends are very sharply increasing. By 2035, 11% of Indian population are going to be obese, and the obesity criteria is more than 30 kg per meter square, which doesn't apply to us. But this is World Obesity Federation, and but importantly, women are developing obesity at much more earlier age and also at much more steeper range. So obesity comes here. So we must recognize it as a disease now. It is not only a cosmetic factor, it is a disease, and it has got the different implication. It has got impairment at normal functioning of some aspect of body, specifically adipocyte, appetite dysregulation, leading to various type of issues. There are characteristic signs also, and there are harms and morbidity also. So we should label it as a disease, and most of the societies are now accepting obesity as a disease. Not only it is a disease, it is a chronic progressive disease with a multiple complication, and we look at this model of managing obesity in the form of adiposity based chronic disease model. It has got multiple implications. Metabolic implications are well known to us. There is cardiovascular disease, dyslipidemia, hypertension, coronary artery disease, atrial fibrillation, heart failure, type 2 diabetes, and pre-diabetes and gestational diabetes. All they are there. NAFLD is there. Infertility, gallstone, but importantly, mechanical factors are there like chronic back pain, osteoarthritis, incontinence of urine, sleep apnea, and there is CNS disorder, that is anxiety and depression in more than 80% of patients who are obese. Now, how this obesity comes into picture? You can see the transition of adipocytes, which are normal adipocyte, which are healthy adipocyte. Adipogenesis is increasing, cell volume is low, more insulin sensitive, and less amount of inflammation. Whereas once there is overflow or excess calorie, adipogenesis decrease, rather adipolysis is there or lipolysis is there. Cell hypertrophy, larger size, decreased blood supply to them, more infiltrated with inflammatory cells, more macrophage inflammation is there, producing lot of inflammatory markers, and that sets into a stage of chronic inflammation and oxidative stress, and we call this stage as a adiposopathy. There is various pathological complication of adiposopathy targeting all organs, right from heart, brain, kidneys, liver, and all your joints, muscles, and respiratory functions. All are being targeted very greatly by this adiposopathy. There is key relationship between adiposopathy and diabetes. There is bidirectional relationship. Lot many are the risk factor of both development of adiposopathy and diabetes, common soil of origin, and both of these two conditions leads to important core defect, increasing insulin resistance and beta cell decompensation. Insulin resistance both at the level of muscle and also at the level of liver and also at the level of adipose tissue. So what is the driving factor of this obesity? There is a key balance of calorie intake and energy expenditure, but that get disrupted. But this balance is regulated by a very great harmonized pattern. There is multi-hormonal control of food intake and body weight, and signals come from your adipose tissue, from your pancreas, from your GI, and all your sense organs. They lead to signals that you should take food, that is orexogenic signal, and the key hormone is ghrelin, and there is signal which leads to tell you that there is satiety or decrease or less or appetite or you are feeling full. There are hormones like insulin, amylin, PYY, cholecystokinin, GLP-1, and leptin. They are all working in together to make you full, and they regulate the food intake and calorie expenditure. This is the basic anatomical architect and physiological architect that tells you how the hypothalamus in hypothalamic inflammation, the key center of this balance is at the level of hypothalamus, at the level of arcuate nucleus, paraventricular nucleus, and nucleus tractus solitarius. The alteration happens in a way that you have more orexogenic stimulus and there is less anorexogenic stimulus, ultimately leading to multiple comorbid issues. There are more than 200 diseases associated with obesity, and more than 30 cancers are associated directly with obesity. But the key news or the good news is that if you lose just 2%, 3% of body weight, 0 to 5% of body weight, you will find there is improvement in hypertension, there will be improvement in hyperglycemia. If you lose further body weight, 5 to 10%, you will be getting all benefit: urinary stress incontinence, prevention of type 2 diabetes, PCOD improvement, dyslipidemia improvement, asthma improvement, NAFLD improvement, very significantly. And if you lose more weight, 10 to 15%, NASH will be improved, OSA will be gone, GRD, knee osteoarthritis, all will be improved very significantly. And if you lose more than 15%, this is the wishful thinking. CVD will be definitely improved. Left ventricular hypertrophy will be going back. NASH definitely remission will be there. Even early fibrosis will be going back. Remission of type 2 diabetes will be there, and significant improvement in CV mortality. So this is the good news. Now, how to measure obesity? There is always a discrepancy that we should look at body mass index or we should go away from BMI. I think the recent guidelines stays with BMI. BMI is aptly suited to Asian population also. Yes, we have got different criterias. It is 23 kg per meter square, which is important for us. That figure, we have got normal BMI from 18.5 to 22.9. Anything above 23 kg per meter square, along with insulin resistance, we label it an obesity. Further, we have got more issues like increasing waist circumference, marker of insulin resistance, target organ damage, then we will label it as stage 2 in obesity. But there are limitations in BMI. BMI basically measures excess weight rather than excess obesity, does not differentiate where the fat is located because location is more important. It doesn't lead to any indication towards a lean body mass. Even your bodybuilders, athletes can have high BMI. Does not assess the visceral fat, and there is ethnic variations also. And I've just told you it is 23 kg per meter square for Asian population. Waist circumference is important. It gives you an indication of central adiposity. 90 centimeter or more for men, and criteria for women is 80 centimeter. But there are certain issues to measure it. How to measure it? It is very specifically taught to the patients, taught to the healthcare physician how to measure waist circumference, and that is important. Then waist hip ratio, again, it is again a good indicator, but requires some both. You have to calculate hip circumference and waist circumference. Sometime in females, it will be. Yes, sir.
Yeah.
Hello.
Okay.
Now, these are the cutoff values for women and men for 1, the waist hip ratio, and women 0.8. So all these things are the criteria, but which is more important criteria is the waist to height ratio. Waist to height ratio is much more important, and this ratio proposed a cutoff value of 0.5, and they are both in waist circumference in centimeter and height is also in centimeter. The cutoff is 0.5. This is a very good marker of central obesity and gives a good correlation with complications of related to obesity. Now the question comes, in a continuum of type 2 diabetes, drivers definitely exist long before hyperglycemia. We all know the weak conversion from normoglycemia to pre-diabetes to diabetes starts very early. Obesity, overweight sets in, metabolic syndrome sets in, insulin resistance keeps on increasing, beta cell function keeps on decreasing, incretin effect keeps on decreasing, hyperglycemia keeps on increasing. Early there is impaired glucose tolerance, then there is impaired fasting, and then you develop type 2 diabetes. So this is the known theory for all of us. Now the question comes, what is the evidence that if we can if we interrupt the natural history of progression of diabetes and the complication of type 2 diabetes at the level of pre-diabetes, if we act at this level, can we prevent conversion from pre-diabetes to diabetes? Yes, friends, the answer is very clear. It is from our landmark diabetes prevention program that told us the story of intensive lifestyle modification along with, in comparison to metformin. If you go with an intensive lifestyle intervention with a regular counseling, dietary restrictions, good and physical activity as per the protocol, 58% reduction in over 5 years was there with conversion from pre-diabetes to diabetes was there. With metformin, it was 31%. This was our diabetes prevention program. Now, if we develop diabetes and we are not having, still we don't have any complication, luckily so, can we go to remission of diabetes, or once a diabetic will remain diabetic forever? So the story of remission, it is not reversal, but the story of remission should be there in our mind because we have got evidence. Evidences came from look ahead study, and this study was actually, it was not targeted to look for the remission of diabetes. It was targeted to look at the various primary and secondary endpoint. And in this trial, weight loss was there with intensive lifestyle modification, and this modification led to the weight loss of around 8.6% by 1 year. And those patients who lost around 8.6% by just 1 year, They were having 11.5% chances of going into remission at 1 year, 11% at 2 year, 8.8% at 3 year, and 4 year 7.3%. So it's not a bad deal, not a bad deal as per look at trial. But the more stronger evidence came from direct trial. It was open label cluster randomized trial based on 49 primary care practice. Remember, where we, Dr. Vitul, we are all basically primary care physician. Dr. 49% primary care practices were included, and diabetes duration was less than 6 years. They were not on insulin. Roy Taylor study, very famous study that gave a clear cut answer. If you lose 5 kg body weight, with very low calorie diet, around 850 calories were given to these patients. This was soup to shake type of diet, and in 1 year, 3.6% will be will be going into remission if you lose just less than 5 kg. 5.2% in 2 years. If you lose more weight, 5 to 10 kg, 33% will be in remission by 1 year, 28% will be in remission at 2 years. But if you lose more, 10 to 15 kg, 57% will be in remission. That means HbA1c is less than 6.5 for 6 months and you are not on a drug, not on any drug, only lifestyle modification. 15 and at 2 years, 60% will be in remission. Not a bad deal, yeah, not a bad deal. You can have this 15 kg body weight loss, 86% will be in remission. See, 70% will be in remission at 2 years, 15 kg body weight loss. So we should look at type 2 diabetes management through the lenses of adipose tissue. Try to decrease body weight at least by 5%, 10%, 15%. Keep on increasing the targets and you can do it. Now we have got very good therapies and we can do along with the lifestyle modification. But what is the evidence? If you have got long-term duration of diabetes, if you have got complicated diabetes, still you can manage it by throwing light on obesity and lifestyle. Yes, lifestyle and obesity management, again, very important. You can prevent complications. You can see here, look at trial. That was basically look at primary outcome. Primary outcome of look at trial was composite of death from cardiovascular disease, non-fatal MI, non-fatal stroke, and admission for hospital for angina. There were secondary outcomes also, primary CABG, primary PTCA and CABG, carotid endarterectomy, PCI, hospitalization for CHF, peripheral vascular disease, and total mortality. But those patients who lost more than 10% of body weight, there was roughly around 21% decrease in primary composite outcome, and there was around 24% decrease in secondary composite outcome. So weight loss up to the tune of 10% or more can give you benefit of decreasing these primary outcomes and also secondary outcomes. So how to approach weight loss, how to go through the weight loss? We have got lifestyle modification. Most of us try it but fail because it is not being perceived as an important part and parcel. We are not emphasizing more on lifestyle modification. That is the big issue with all of us. So first and most important cornerstone is a lifestyle modification. Just alter the food habits of the person and try to make him aware regarding consequences of this type of food. That is a behavioral therapy because it is more in the head that is there. It is not in the in surrounding. It is more in the brain. It is requiring more of psycho counseling to regarding obesity management. Then comes the role of pharmacotherapy, and it has evolved and revolutionized very recently. I will be touching about some about the pharmacotherapy. The drugs which are approved for management of obesity in India are only two drugs, orlistat and semaglutide 2.4. Remember friends, liraglutide, which is available to us in these doses, is not approved for management of obesity. It is approved for management of type 2 diabetes. Yes, with obesity, you can use this molecule, but not for obesity management. That is different story. The dosage is different. Naltrexone, bupropion is not available. Phentermine, topiramate are not approved with us. So we have got only two drugs, orlistat and semaglutide 2.4. Semaglutide is going to be launched recently. Next year you are going to have next month you are going to have semaglutide. Already we have got one more molecule that we are using, that is tirzepatide. So now we have got three drugs molecule which are there as a approved drugs for treatment of obesity in India. They are all DCGI approved molecules. Semaglutide we are going to have next month. Semaglutide has shown in STEP trials step 1 to step 4 trial in patients who are having type 2 diabetes, in patients who are not having type 2 diabetes, in patient again in comparison to intensive behavioral therapy, in patients who were with not reaching the targets with obesity and overweight and diabetes, they were put on semaglutide 2.4 milligram at various baseline weight of the patient. Overall, it decreased the body weight by up to the tune of 15 to 18%. So that was a significant amount of decrease in body weight. But what is the issue with these type of drugs, whether you are using semaglutide or you are using orlistat or you are using Monzero or tirzepatide? It clearly shows you it is a lifelong therapy. It is a continuous therapy. Withdrawal of drug will lead to rebounds of the therapy, rebounds of the obesity. So it is a behavioral disease. You have to counsel the patient, you have to stress about the lifestyle modification, and not only that you are on medication, you can stop lifestyle modification or you can go away. Once you are off medication, this rebounds back. So obesity is a chronic disease. It is an ongoing treatment. It is a lifelong struggle. It is a lifelong fight that is required to maintain improvement in weight and but definitely your health.
Sir, we need to
Just a,
finish.
just a three more slides. Terzepatide is there, and this molecule has shown the benefit. It can decrease further weight down up to the tune of 24, up to the tune of say 20% of body weight loss. Surmount trial have shown comparatively Surmount 5 showed much benefit in comparison to semaglutide 2.4. But another molecule which is coming, that is retinorotide. So we are moving from one hormone molecule, that is say semaglutide, dulaglutide, liraglutide, twin hormones in the form of tirzepatide and also in the form of cagrilintide, in the form of serotide. Also, we have got three hormone combined together, that is retinorotide. So it is coming closer to the surgical therapy, coming closer. Where surgical therapy will lead to 26% of body weight loss, retinorotide will give you around 25% body weight loss. So it is not a bad deal. So this is oral sema, which is also coming up in higher dose, 25, 50 milligram. These are Pioneer Plus trial, giving you additional benefit of 5 to 10% more body weight loss in comparison to semaglutide 14 milligram. So summarizing my talk, adiposopathy appears to be contributing factor to higher prevalence of diabetes in India, despite a low prevalence of obesity. That if you define by 30, it is low, but if you define by 23 kg per meter square, it is much more higher. Intervention that target reduction in weight appears to reduce adiposopathy and in turn improving diabetes complications. Targeting 10 to 50%, 15% body weight will give you immense benefit in all non-communicable cardiovascular, non-communicable diseases. And also modalities to reduce body weight appear less important than the magnitude that is important. The amount has to be important, 5, 10, 15. That is the important targets to be achieved. Anti-obesity medications are coming up. We have got molecules with us like tirzepatide, orlistat, and semaglutide coming up. Due to non-availability of other drugs, we should have more emphasis, or the cost is a big factor. We should have more emphasis on lifestyle modification. That is the cornerstone of management of obesity, and also that will help to manage our diabetes in a big way. Thank you for the picture this time.